Urine formation begins with filtration, which takes place in the renal corpuscle. The renal corpuscle consists of a Bowman's capsule, a cup-like sac which surrounds a specialized capillary network called the glomerulus. As blood flows through the glomerular capillaries, fluids and substances from the blood plasma spill out and are collected in Bowman's capsule, forming the filtrate. The filtrate will eventually become urine. The criteria determining whether the substance will be filtered are size and charge. Substances that are filtered include water, glucose, sodium chloride, amino acids, small proteins, metabolites, and urea. Substances that are generally not filtered include medium to large proteins, red blood cells, white blood cells, and platelets. The filtration barrier, the substances that must cross, consist of 4 potential obstacles. One is the fenestrated endothelium of the glomerulus. This layer contains pores called fenestra and negatively charged glycoproteins. Red blood cells are prevented from filtering, and the negative charges impair the filtration of negatively charged proteins. The basement membrane of the endothelium is a porous matrix of anchored negatively charged proteins that acts as a charge-specific barrier, primarily selecting against negatively charged substances, though smaller ions like chloride and bicarb are freely filtered. Visceral layer of Bowman's capsule. These specialized cells have long finger-like processes that encircle the glomerulus capillaries. These processes interdigitate, forming filtration slits bridged by proteins, which function as both size and charge selective filters. Then lastly, we have the mesangial cells. These are interspaced throughout the glomerulus capillaries. These cells can contract to change the surface area of the capillaries, thereby influencing filtration. They also have phagocytic activity and secrete local regulatory hormones. There's lots of pressures involved in filtration. And the main outward pressure forcing blood through the glomerular filters is the hydrostatic pressure of the glomerulus, which is carefully regulated between 50 to 55 millimeters of mercury. Glomerulus capillaries have significantly higher pressure composed to most other capillary beds, which is necessary for filtration. This outward pressure is resisted by 2 inward pressures: hydrostatic pressure of Bowman's capsule, typically 15 millimeters of mercury, created by the hydrostatic fluid already within the nephron. Then you have oncotic pressure from the glomerular capillaries, also known as blood colloid osmotic pressure, roughly 30 millimeters of mercury, created by proteins that remain in the capillaries and draw fluid back in. The net filtration pressure is calculated using these different values. The glomerular filtration rate, or GFR, the normal rate of filtrate formation is 125 milliliters of plasma per minute. And that is known as your GFR. GFR is crucial diagnostic test for kidney function. When we talk about renal clearance, it is a measurement that compares the rate of a substance is filtered and reabsorbed/secreted with the rate at which it is excreted in the urine. It represents the volume of plasma completely cleared of a substance per minute. To estimate GFR, the substance used for clearance must meet strict criteria. It must be small and non-charged, not reabsorbed, secreted, degraded, or produced by the nephron. Creatine is a metabolic product which fits the criteria and is produced at a constant rate. Therefore, creatine clearance provides a good estimate for GFR. If blood creatine levels begin to increase, it indicates that the kidneys are starting to fail. Inulin is another substance that have the same clearance as creatine, indicating filtration efficiency. Clearance values can also reveal how kidneys handle other substances. If clearance is below creatinines, it implies reabsorption has occurred. If clearance is above creatinines, it implies secretion occurred. Regulation of blood flow to the glomerulus. The kidneys employ an autoregulatory mechanism to maintain glomerular pressure around 55, even with systemic blood pressure fluctuations, ensuring that your GFR will remain the same. These responses, there's 3 of them. The first one is myogenic response. This is an intrinsic property of smooth muscle. If systemic blood pressure increases, the afferent arterial wall stretches, activating calcium channels. This causes smooth muscle contraction and vasoconstriction of the afferent arteriole, reducing blood flow to the glomerulus and returning pressure to normal. The second one is the tubuloglomeralar glomerular feedback. This system involves macula densa cells located at the junction of the ascending and distal tubules, which monitor sodium and chloride concentrations in the filtrate. If these cells detect lower than normal sodium and chloride, they release a paracrine hormone called nitric oxide, which helps vasodilation of the afferent arteriole. This increases blood flow and helps maintain glomerular pressure. Conversely, macula densa cells can also induce vasoconstriction by releasing adenosine. This close association of the macula densa cells with the afferent arterioles forms the juxtaglomerular apparatus. The last one is nervous and endocrine systems. In cases of severe blood loss and low blood pressure, we have our sympathetic neurons that are going to release norepinephrine, which are going to act on alpha-1 receptors at the efferent arteriole to vasoconstrict. We also have antigenesin 2, which is going to cause the efferent arteriole vasoconstriction. Both actions are going to cause a backup of blood flow, increasing pressure to the glomerulus. When we talk about reabsorption of solutes and water in kidney tubules, the primary function of the nephron tubules, particularly the proximal tubule, is to recover the majority of fluid or water and solutes that were filtered at the glomerulus. Without this reabsorption, the entire blood plasma volume would be excreted in about 20 minutes. In the proximal tubule, this segment reabsorbs the largest fraction of filtrate, approximately 70% of filtered sodium chloride and water, and 100% filtered glucose and amino acids. The sodium reabsorption primarily occurs through secondary active transport with sodium. This process is powered by the sodium-potassium ATPase pump on the basolateral membrane, which creates a large electrochemical gradient for sodium to enter the tubular cells from the filtrate. Glucose and amino acids, these are reabsorbed into the enterocytes from the lumen via sodium co-transporters on the apical membrane driven by the sodium gradient. Fructose uses facilitated diffusion via GLUT5. Once inside the cells, they exit to the blood via basal transporters. Renal threshold and saturation. The reabsorption of substances like glucose is protein specific and becomes saturated. If blood glucose levels exceed the renal threshold, the reabsorption proteins in the proximal tubule become overwhelmed, leading to glucose excretion in the urine, as seen in diabetics. Each filtered substance has its own renal threshold. Water reabsorption is strongly coupled with sodium reabsorption. As sodiums are reabsorbed, it is strongly water flows passively by osmosis, primarily through aquaporin channels, maintaining the fluid in the proximal tubule lumen as essentially as isoosmotic with the blood despite the massive reabsorption. This phenomenon, where water drags other ions like calcium and potassium along it, is called a solvent drag. When we talk about chloride, the second half of the proximal tubule is a main site for chloride reabsorption. This occurs as chlorine concentrations increase due to aggressive sodium reabsorption in the first half, driving a passive reabsorption or through specific antiporters and symporters. Potassium is reabsorbed via solvent drag in the proximal tubule. When we talk about secretion, the proximal tubule is also vital for secreting substances from the pertubular capillaries into the tubules. This allows for efficient removal of substances that might not have been fully filtered, or for fine-tuning acid-base balance. The example of penicillin demonstrates how competitive secretion can impact drug half-life. If we talk about T/F/P ratio, this is a ratio that's going to compare the concentration of a substance in the tubular fluid to its concentration in the plasma, and helps understand reabsorption/secretion. A TFP ratio of 1 indicates that the substance is being reabsorbed at the same rate as water. A ratio greater than 1 indicates that the substance is not reabsorbed, so its concentration increases as water is removed. A ratio less than 1 means that the substance is reabsorbed more quickly than water. A very high ratio indicates secretion in addition to filtration. When we talk about hormonal regulation and urine concentration, we're using something called the renin-angiotensin-aldosterone system, or RAS. So this system plays a crucial role in long-term blood pressure regulation, primarily by altering blood volume and vascular smooth muscle tone. So step 1 is renin release. The system begins with the release of this enzyme produced by specialized juxtaglomerular cells in the kidney's afferent arteriole. Renin release is triggered by a decrease in GFR or a decrease in blood pressure. It will then activate angiotensin 1 formation. Renin, a plasma protein produced by the liver to cleave renin into angiotensin 1. Angiotensin 2 is then formed by angiotensin 1 by an ACE enzyme, which is highly concentrated in the capillaries of the lungs. The effects that angiotensin 2 can have, it's going to have 4 major effects. It stimulates the release of aldosterone from the adrenal gland. It preferentially causes vasoconstriction in the efferent arteriole, which backs up blood flow and increases pressure of the glomerular capillaries. It is a potent vasoconstrictor of the systemic arterioles, increasing peripheral resistance and venous return to the heart, which raises blood pressure. It can also induce the release of ADH from the posterior pituitary gland. Clinically, ACE inhibitors are used to reduce blood pressure by blocking the production of angiotensin 2. When we talk about cellular actions of ADH and aldosterone, very quickly, aldosterone is produced in the adrenal cortex. Its primary role is to regulate extracellular fluid volume by influencing sodium reabsorption. When we talk about ADH, this is produced by the hypothalamus and released from the posterior pituitary gland. ADH primarily regulates plasma osmolarity. It also has a lot of vasoconstricting effects. When we talk about the loop of Henle, renal medullary concentration gradients, this all has to do with the different limbs of a nephron. When we talk about the descending limb, this segment is highly permeable to water due to the presence of aquaporin channels, but largely impermeable to ions. As filtrate descends into the increasingly salty medulla, water moves out by osmosis. We talk about the ascending limb. This segment is impermeable to water but actively transports sodium chloride out of the lumen into the medullary interstitium. This active transport is mediated by some symporters. As sodium chloride is removed, the filtrate becomes progressively more dilute. When we talk about ADH and excretion of urine on different concentrations, in lots of different states, the collecting duct is going to play our final regulatory role in determining urine concentration, and it begins in the cortex and descends through the salty medulla. In conditions of dehydration or high ADH levels, the posterior pituitary is going to release that ADH. It's going to bind to receptors on the cells of the collecting duct, which is going to allow aquaporin type 2 channels to be open on the plasma membranes, which is going to allow water to be able to flow back in, so we are no longer dehydrated. In conditions of hydration, when we have low ADH, ADH release is inhibited and the aquaporin channels remain concealed on the inside, making that last part not permeable to water, which will then have a very dilute, high volume of urine. If we talk about diuretics, these are substances that promote urine production, often by interfering with salt reabsorption in different parts of your nephron. By preventing salt reabsorption, they hinder symporter thiazide blocking sodium calcium symporters. By preventing salt reabsorption, they're preventing the medulla's ability to maintain its tonicity, thus reducing water reabsorption even if ADH is present, leading to an increased urine excretion. Some diuretics also work by blocking ADH receptors.